Broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. We're so glad that you could join us on this snowy Tuesday. Kendra, I'm going to hand it over to you now.
Sure. Thanks, Mary. Good morning, everyone. My name is Kendra Snuffer, Chief of Staff with the Office of Mental Health and Substance Abuse Services. I'm just kicking us off here today on behalf of Deputy Jen Smith to welcome everyone to the Mobile Crisis Evolution webinar. We really appreciate you taking your time out today to be able to join us and learn more about the SAMHSA pathways for all things crisis. And we have some of our awesome OMSA staff who have been working diligently on this effort here to walk you through that today. Jenna, would you like to go ahead?
Absolutely. Thanks, Kendra. So I'm Jenna Maynard-Baker, the Bureau Director for Policy Planning and Program Development within OMSAS. And Steve, do you just want to introduce yourself?
Sure. Good morning, everybody. My name is Steve Ross, and I'm part of the crisis team here at OMSAS.
Great. So Mary, if you could advance to the next slide for us. So we're going to spend a little bit of time today talking about the changes in the crisis system regulations specific to mobile crisis. So I'm hoping that we can move our slide forward.
It's circling, hang in there.
So many of you hopefully have heard some of this information I'm going to provide, and I will also say, as we're waiting for the computer to be our friend, that we are also engaging, Steve and I, in conversations directly with providers, with their mental health administrators about the different challenges in different communities across the Commonwealth as we work to implement the SAMHSA roadmap. So if you have not seen the SAMHSA guidelines to the ideal behavioral health crisis system, which you can very easily find by Googling just what I said, and maybe Steve, you could just put that in the chat there, you will be able to understand that we are not being creative. We are really following the federal guidelines for the modernization of the crisis system to increase access, really is a big focus. Mary, can I have the next slide? So, we know that there are long wait times for lots of services. We know people are boarding in emergency departments. We also want to, have the same access to care of immediate access to care that physical health has, which is really the standard for the crisis system. If I break my leg, I'm going to get, an ambulance to come. If I can't move, I'm going to get an ambulance to come to me. I'm going to be brought into a care set, somewhere, an emergency room. I'm going to get the care I need quickly. And that is really a big part of why SAMHSA has made modernizing the crisis system their #1 agenda. SAMHSA meaning the Substance Abuse and Mental Health Services Administration of the federal government. That is starting with 988, but that is, we're going to talk about the part that mobile crisis plays today. And I'm sure that many of you are familiar with the 2016 Stepping Up initiative to eliminate the criminalization of mental health symptoms that happens when law enforcement responds. That same year, the Chiefs of Police Association did their One Mind campaign, calling for all 100% of police officers to be mental health first aid trained and 20% to be certified in CIT. So this is really a big part of this modernization of the crisis system. Is not something that Pennsylvania just decided to do or is doing independent of all other states. It is something that is happening nationwide. Next slide. So now Steve's going to take over for a little while. Steve.
Thank you, Jenna. Good morning, everyone. Again, my name is Steve Ross, and I'm part of the crisis team here at OMSAS. I'd like to start off by thanking all of you on the phone today for setting some time aside from your very busy schedules to participate in this webinar. Some or many of you, depending on who is on the call today, may have heard or seen some of this before, so I apologize in advance if that's the case. However, as Jen and I have been out across the Commonwealth recently having discussions in counties, including some providers, we've encountered quite a few instances where we've heard comments like, "Thank you, I didn't know that," or "This is the first time I'm hearing about this." So we wanted to make sure that we made this opportunity available to be certain that all of our licensed mobile crisis providers had access to and are aware of this information so that they can begin to prepare for the upcoming changes in our crisis delivery system instead of waiting for the revised regulations to take place. Our current crisis system is operating off of 1993 unpromulgated regulations. So taking these steps to bring crisis services into alignment with this new vision of SAMHSA is quite an undertaking for all of us. SAMHSA's vision of integrated crisis outlines the expectations of our crisis system going forward, not just for Pennsylvania, but for all the states in our nation. Over the next few slides, I will provide a high-level overview of what that vision will outline for us as we move ahead in implementing these changes in Pennsylvania. This PowerPoint, by the way, will be made available afterwards on SAMHSA's website, so you can share it with some of the partners in your organizations or go back and view it again if there's something you wanted to catch up on. So SAMHSA in 2020 released this best practices toolkit containing national guidelines for behavioral health crisis care. This toolkit, which is about 80 pages long, outlines the expectation in their vision of crisis systems in our nation going forward. You can see the link on this slide will take you directly to the toolkit, or as we put in the chat, you can simply Google SAMHSA's crisis toolkit and gain it that way. The principles of these best practices for crisis systems moving forward are simply predicated on three basic principles. Number one, someone to call. Number two, someone to respond. And number three, somewhere to go. So let's start with the first one. Mary, can you advance the slide, please? Okay, so someone to talk to or someone to call. This is referring to our 988 call centers. Pennsylvania launched 988 midway through 2022, and these call centers are staffed 24/7, 365 with trained individuals to support folks experiencing a crisis and assist them in getting them connected to the help that they need. From the data that we've thus far collected from Vibrant, only 10% of the calls have required additional services beyond that point. The number of call centers that we have has fluctuated slightly since its inception, but we currently have 12 call centers answering calls regionally across the Commonwealth, with another 2 call centers currently in the onboarding process. This does not necessitate replacing county hotline numbers that have been in place and are in place for decades, but can serve as yet another resource for a way for people to access services. SAMHSA's benchmark in this area was a 90% in-state call answer rate by the end of 2023. And despite all the bugs that we've had to work through in implementing 988, we ended 2023 at 89%. So we're pretty close. Mary, advance to the next slide, please. So the second guiding principle is someone to respond. And that's where you all come in. This is referring to mobile crisis teams. In an attempt to decrease the emergency room boarding issues we experience, as well as law enforcement responding to folks in crisis when there is not an immediate threat or danger, there is an increased focus on mobile crisis teams responding to people in need where they're at in the community to support, provide support, de-escalate the crisis situation, and get individuals connected to the appropriate services and resources. There is a heavy emphasis on inclusion of peer supports on the teams because we know that we all know how effective it is to have somebody with lived experience to relate to. As a result, changes to the revised regulations in this area will identify mobile crisis teams as teams of at least 2 individuals staffed by behavioral health professionals and ideally a peer support specialist to be available 24/7, 365. And as you can see from the slide, SAMHSA's benchmark is for Pennsylvania to make rapid mobile crisis response available 24/7 via this team method to 80% of the population by the end of 2025. Advance to the next slide, please. And the last guiding principle in the toolkit is somewhere to go. And this is referring to emergency behavioral health walk-in centers. These centers will serve as behavioral urgent care for folks experiencing a mental health and/or substance use disorder crisis, and is designed to stabilize individuals, assess their needs, provide medications if necessary, and develop a care plan to get them connected to the services they need, with a design to have the engagement be less than 24 hours. These walk-in centers can serve as an alternative to emergency departments and will accept all patients, voluntary and involuntary, without requiring medical clearance. Now, we understand that there will be some medically complicated individuals who will need to go to the ER, but these centers will be able to address many of our folks experiencing crisis who don't have extensive or life-threatening medical concerns. These walk-in centers will also serve as a diversion from the criminal justice system, giving law enforcement a drop-off point for individuals in crisis instead of taking them to the ER or incarcerating them. These walk-in centers will be staffed with medical professionals capable of diagnosing and prescribing medications. And again, there is a heavy emphasis on embedding peer support specialists in these walk-in centers. SAMHSA's benchmark on this best practice is that 80% of the population have access to these centers by the end of 2027. We understand that all of this is quite an undertaking. This is indeed a system transformation system transformation. And here in Pennsylvania means changing regulations that are over 3 decades old. We also recognize and thank you all out there for the great work you've been doing along the way. We also know the needs of the folks in mental health and substance use disorder crisis are more prevalent today than ever. We also understand that implementing this new vision of crisis doesn't come without growing pains. We've heard concerns about financial sustainability and workforce issue, and we're recognizing that implementing these systems will take time. It's our hope to get out there over the next couple months and meet with the mobile crisis providers in person to listen to and hear your concerns, and for us all to work together to find solutions so that we can enhance this system in a way that not only meets SAMHSA's expectation, but more importantly, provides the most effective, timely services and resources to those that we serve. And now I will hand it back over to Jenna.
Great, thank you, Steve. So just kind of updating, you've kind of heard the vision, heard the SAMHSA guidelines, and where we are right now, and also you've heard some of obviously what will be different, but we did issue a bulletin that said counties no longer are required to operate their crisis lines. Previously, the Mental Health Procedures Act mandate that they have emergency services was interpreted by OMSAS to include crisis lines, but that bulletin was released, and so counties can choose not to have their lines should they make that decision. When it comes to our 988 call centers, we currently are at an 89% answer rate as of December. You heard the goal was 90% by the end of December, so we're very close. We've also listening to county mental health administrators and 988 call takers and other folks, mobile crisis providers, heard the need to make sure that if a 988 call rings into the call center in Butler County, but the individual is physically in Monroe County, that the 988 call taker could log on to some type of database, which we have secured for them. We call it Apricot, and specifically see the crisis resources. This is not replacing 211 or any of those other systems. This is specific to a crisis resource database that the county mental health administrators are to update with their current crisis providers, and 988 call takers can see where those crisis resources are, regardless of where the call came from across the Commonwealth, so that, because it rings a certain number of times at one call center and then it bounces to another in-state call center. So there will always be times that 988 call centers are answering calls that are not in their community. Therefore, it's critical they are able to see what the crisis resources are, because one of the clear expectations of 988 is that they are able to real-time deploy mobile crisis teams, and that a mobile crisis team will be called when an individual cannot be de-escalated on the phone and clearly needs to have a person engage with them. And ideally, you know, the mobile crisis team would respond. They could, you know, try to help de-escalate, and if necessary, then bring them to an emergency behavior or have them transported to an emergency behavioral health crisis center. So the connection between 988 and mobile crisis is very clearly articulated by the federal government in terms of like not it becoming 911, like how they deploy law enforcement. So I think, you know, as we think about other updates within our system, I'm sure most of you are aware that the 302 bulletin was revised to make it really clear what is intended in the law, that there's an imminency standard. That means the life of the warrant is hours, not days. And it also very clearly clarified that an individual serving a warrant days after it's been issued has the right to determine if it's still valid. You know, many other states, a warrant cannot be issued unless an individual actually, a professional, engages face-to-face with an individual. And so our system that often, you know, that on occasion allows for hearsay to be the standard for a bulletin, for a warrant to be issued, you know, really the goal is that mobile crisis would engage with a person before a warrant is issued. So, you know, obviously, as we've talked about the regulations, we operate on 1993 unpromulgated crisis regulations that uses a statement of policy for licensing. And we are very much adhering, but I want to stress not all the way adhering, in the sense that, you know, we're talking about 2-people teams, and I am very aware that there are many places that use one-person teams. But the national standard is actually that there's a licensed clinician on each team, and we are not requiring that in our regulations because we realize it's simply not feasible for the Commonwealth. We had a CMS grant of mobile crisis and surveyed what was the current workforce and determined that there are just simply not enough licensed individuals to try anywhere close to that mandate. That is SAMHSA. So folks see that there's a special state plan amendment we could do for mobile crisis, and they're wondering why we haven't. That is because having licensed clinicians on the team is an expectation of that specific state plan option. And we have, and many of you as mobile crisis providers are aware of this, and I know that some of your mental health administrators actually applied for money to support their mobile crisis providers, but we've distributed $41 million in ARPA money specifically focused on the crisis system. We obviously have invested much more than that with CAA dollars before that, and always the 5% set aside for community mental health services block grant dollars, and many reinvestment plans all across the Commonwealth have been focused on crisis services as well. Next slide. So a few things for us to talk about. You know, we have successfully now, through our state plan amendment, the bulletin is still pending, and I want to be clear about that, but we have changed our state plan amendment, and we are working, you know, the Pennsylvania peer support, working with them as well. What has changed, though, is the qualifications to become a CPS no longer requires an individual to identify as having a serious mental illness. The standard now is identifying as a person with a mental health diagnosis through a self-attestation, in which you are not required to share anything more than that. That is the national standard. We were clearly innovative in one of the first states to create standalone peer support as a billable service and the CPS certification. But in doing so, we hadn't updated that with the times to be more inclusive, as is the national trend now. We also have secured an award from the National Association of State Mental Health Program Directors, listening to providers who said, okay, if there's 4 hours of pre-service required in the new regulations, which there are, you're going to tell me I hire one crisis worker, I have to spend 4 hours doing one-on-one training. And so what we decided to do through this project that was funded by NASHBID is to use MyOMSAS. So if you're familiar with MyODP, we have MyOMSAS and we're building it out. It's an online training platform, which is free. And we plan to continue to load a whole lot of stuff in there. But what we are doing with the crisis intervention worker certification is that we are going to load up and we're creating specialty modules. They will be loaded up, and they will include anything that we have proposed to be required in the regulations, so that you could hire one person, put them in front of the computer, have them watch the required and participate in the required trainings, and whenever it worked for you and them, and they then would meet that requirement and at no cost other than staff time to do so. If someone chose to do all of the CEs that all of the ones we're loading up on there, and then an in-person de-escalation day and an in-person mental health first aid day, they will receive 30 free CEUs. And given that Temple's our partner, those CEUs will count for licensed people as well as peer support folks. So that is something we're very much working on to ensure that we are able to not create a burden on providers by having more specificity about expectations related to crisis staff. And those training requirements will apply across the board for all the modalities. So folks will need to have that training, whether they're mobile crisis or working at a crisis stabilization program or a emergency behavioral health walk-in. And we are very aware that for a very long time, the MA requirement that has been in place since we added crisis intervention to our state plan, that a licensed professional recommend the deployment of a mobile crisis team. Now, historically, stabilization programs have gotten a recommendation from a licensed practitioner of the healing arts, but mobile crisis has not, often because there are no clinicians. And also, the deployment of a mobile team is not a clinical decision. It's really an assessment and intervention decision. And it is required, even though our programs are largely paid through alternative payment arrangements with their BIMCOs. This is still an MA payment regulation on the federal level. And just as a reminder, always, we can never waive federal rules. We have no power to do so. So in the new regulations, we are including, proposing to allow the licensed bachelor level social worker, which was created in 2020. Pennsylvania is the second largest educator of social workers, only second to New York State. The license simply requires a BSW, and then the person passes the exam. But about 50% of the exam is on assessment and intervention. And once again, deciding to send a mobile team is an assessment based, for an intervention. It is not a clinical service. So it is our intent to have us come in alignment with that requirement by SAMHSA, requirement by CMS for MA dollar payment to allow to have LBSWs, of which there are many, many in the Commonwealth. And we are working on some recruitment strategies to call them in, to bring them into crisis, whether they're working at 988 call centers or they're working on mobile crisis teams themselves. That's how we'll be able to meet that requirement for federal payment. Next slide. This is just a quick chart for you if you're curious, about the changes that we intend to make. We obviously already made the change about the self-identifying, as an individual who has had a mental health diagnosis, rather than identifying as an individual with an SMI. It's also our intent to no longer require people to show their high school diploma or their GED, instead to have a literacy test in the form of an essay. I say all the time, I think most of us don't have our high school diplomas or physically in our possession. And so it has served as a barrier for folks, not that they haven't had them, but trying to find them, locate them, and so the goal here is that we obviously need folks to be literate enough to complete MA paperwork. So an essay is replacing that. And the final one that we're proposing to change is that, there were several folks who, in the not even 2 years I've been in this role, who had chosen to be stay-at-home parents and had done that for several years and were really in a great place and wanted to go back to work part-time while their kids were in school, but they were not eligible because you had to be, the 3 years in paid or voluntary or in school, or so it was, that was just limiting in a way that wasn't helpful. And also in conversations with the National Association of State Mental Health Program Directors, they've strongly urged us that it's our job to create the basic qualifications for certification. It's employers' decision who they hire, and we should not narrow the possibility of options for providers. Providers should be selecting the folks that they feel best meet their needs, and that certification should be a basic competency, not a weeding out process. So that is that their conversations also greatly informed our approach. Next slide. So Steve already pointed this out, and as Steve also pointed out, we are happily going around to have lots of conversations where we ask, you know, what's going well, what are your challenges, and what are your challenges with what's coming, and how do we help address those in any way we can. As I said, we're working on a statewide recruitment campaign for BSWs. We addressed the issue related to the narrow scope for peer support. We are evaluating the possibility of creating a family peer support. The new regulations will say any peer-based certification is eligible to work in the crisis system as a crisis intervention worker. So that also includes CRSs. So we're supportive of and have paid for some crisis endorsement trainings for peers. So beyond the basic certification, they can take the endorsement training to focus on crisis. So we know that 2-people teams who respond 24/7 is not the standard across the Commonwealth. We realize that, you know, it's definitely present in more urban areas, but it is not present in other parts of the state. It is the expectation in the regulation, and it is the expectation where the nation is moving. The Department of Justice recently entered into a consent decree with a California county because they said that if all a county has to respond to a person in a mental health crisis, you know, at 7 o'clock at night or 8 o'clock at night, if all they have to respond is law enforcement, that they deemed that to be a violation of the Americans with Disabilities Act and the Olmstead decision. That the assumption that a person with mental illness needs a public safety response, they found to be discriminatory. And so it is a big part of why the toolkit calls for 24/7, 365 mobile crisis, which once again, we know is a lift for many parts of the Commonwealth. That is the expectation. And also that mobile crisis will respond if law enforcement is dispatched to a scene and there is no public safety risk. There's an individual experiencing a psychotic episode, and that they've already been to that house 10 times in the last 2 weeks because the individual feels there's someone in the house, and they feel like, okay, somebody else needs to engage with this individual because they don't need us to check their basement again. They need something more than that. That mobile crisis would in fact respond and serve as the gateway to the mental health system, or even just to de-escalate, or even to create a pathway of having this individual call 988 instead of continue to call 911. Because, you know, we really want to make sure that law enforcement is engaged when there's a public safety risk, and law enforcement is not engaged when there is not a public safety risk. And, you know, it is an expectation for 988 and mobile crisis by the federal government that we will need to start tracking the response time from dispatch, you know, the time from dispatch until the person responds, the length of time of engagement, the outcome of that engagement for mobile crisis. Virginia has this amazing dashboard that has all this demographic information and response time information, because it is much intended to be the counterpart to 911 and law enforcement or fire response. So it also means that we need to make sure that we are helping figure out how to ensure that mobile crisis teams have collaborative relationships with their 988 call centers, and that the 988 call centers have the ability to deploy mobile teams with someone, as we said, with someone holding a license recommending the use of that mobile team. That recommendation does not mean the individual who's licensed needs to speak to the person who needs the response. It simply means they need to be consulted, and their name and license number need to be recorded on the record. Next slide. So this is just a slide about what I mentioned with LBSWs. You know, a crisis intervention service licensed behavioral health professional shall be one of the following. It is our goal to meet this requirement that has been in place for a very long time with an LBSW if that is the option that works best. So this is just what we are proposing to do. It will be in the regulation, and it is our goal here that there are no surprises, that folks are not anxious or worried about what might be in the regulations, that you are aware now and telling us what we need to do to be helpful to meet them, because they already are a little bit lower than the standard that SAMHSA is advocating for. And I'm happy to share with anybody like Washington, D.C. or any of these other folks that have done more recent regulations do things like require a licensed professional on every crisis team. And we are not, we're not doing that, but we do have to do this slide for federal payment rules. Next slide. So this is, and if you've heard me speak about this, you've seen my ability to create graphic design, because this is about it. But I know that some folks do well with images, including myself. And so, you'll see here that it is our goal that it is the integrated behavioral health crisis system. It is not a separate system from SUD. So if you don't know Steve, I will share with you that he was the SCA in Luzerne County, and it is a big part of why I recruited him from DDAP, because I want to make sure that we here at OMSAS are very dedicated to making sure that it is the integrated behavioral health crisis system, and that we will work closely with SCAs as well as mental health administrators as we do this rollout. For instance, if someone calls 988 and they want to access treatment, the 988 call centers have been instructed to contact, do a warm handoff to get the DDAPs Get Help Now. The walk-in centers will do comprehensive assessments of both, mental health and SUD related challenges that an individual is experiencing that moment, and figure out what's the right course of action for them. Crisis stabilization is a short-term bed, as we know it is crisis residential right now. The regulations propose a 7-day initial stay with 2 additional days. The regulations will propose to have separate standalone peer-run crisis stabilizations. We currently issue 4 waivers allowing that to happen, and it's our goal to have them happen without having to have a waiver. If you're at all familiar with People USA, they are the largest peer-run crisis provider in the country, and they do everything from mobile crisis all the way through to crisis stabilization. And so we want to be able to embrace peer-run programs within the crisis system as well. So this is, kind of the map of what we're aiming for eventually, knowing that this is a humongous systemic change effort that will hopefully help us stop folks waiting for long periods of time in the emergency department, or individuals with mental illness who have struggled for years being incarcerated in county jails at high rates for symptoms of their illness, such as, not listening to an officer when they're told to move, and that becomes trespassing, become a little difficult, it becomes a resisting arrest, and all of a sudden someone is incarcerated for a long period of time when it's really related to symptoms of their illness. So it is not a small effort, but it is a critical effort, and we're really hopeful that we can be as supportive as possible in all of this. And we know that workforce and fiscal sustainability are overwhelmingly the challenges that are faced by providers. If, we go to everything and anything people invite us to, and so we hear those conversations over and over again, and we are well aware, and we are not of the opinion that those are your problems to solve. We are working and thinking creatively and talking to everyone we can to come up with workforce strategies and financing strategies. Obviously, new regulations will mean new rates, but we also realize that it is a significant change for mobile crisis from what was before. So there's one more slide, Mary, that just has some, that's my email, which I think most folks already have. But also, if you aren't on the OMSAS listserv, please consider joining that, because we do send, sometimes I hear, well, how come someone knew something? And I'm like the peer information. We sent that out on the listserv. So we really try to make sure everybody's on the listserv, so everybody feels like they get the information at the same time and they don't hear it from someone else. And and think that we just neglected to tell them. That is the avenue by which we disperse information. I don't see, I'm trying to see if there are any, there is the question feature in the.
I don't see anything in the chat box, Jenna.
Yeah, there's the chat and then there's a questions feature. So they're both there. And I don't see anything either. So I don't know if anybody has any specific question for us that we can address for you now. As we said, we are working to meet with mobile crisis providers and their county mental health administrators to figure out what else we need to know as we go through this work. And so we're hopeful that folks are open to that. The ones we've met with so far have been great conversations, but we do want to make sure that we are answering anything that right now that we can answer.
Jenna, this is Mary. Would you like me to read the questions to you?
There are questions. I don't know why I don't see them.
I'm not sure either. The first one is.
I've got them now. I got them to pop
Okay.
out.
All right.
Thank you.
Sure.
So the first one from Mike, what is the expected sustainable funding stream for walk-in centers? So the emergency, when we say walk-in centers, you mean emergency behavioral health crisis walk-in centers. And I say that long title because they are intended to be an alternative to an emergency department. And so they will be, obviously there will be a rate that supports the level of care that's provided there. And a big part of also why we call them emergency behavioral health crisis walk-in centers is we're very focused on making sure that their private insurance pays as well for these facilities, because they will be used by all folks. So the expanded mobile service is definitely, we realize that working 24/7 two people teams will cost more. And so that is also a consideration that we're well aware of and had, and the BIMCOs are well aware of as well. Can you talk more about the 988 call centers to deploy a mobile crisis team? The counties are only to provide phone numbers to 988. The thing is, so it says it should be discussed with, and then Judy doesn't say who, but yes, I mean, the system design on the federal level is that 988 gets a call, they make a determination, they do everything they can to de-escalate the call there, and then they make a determination that a mobile team needs to go out and they deploy a mobile team. That is the vision for 988, and they have the ability, to do so. We will probably end up having to buy statewide some type of software to make that happen, because in other states they all have tablets and they're tracking, because we are behind. I mean, I'm not going to pretend we are behind most other states in their crisis system, except super rural states. But so it's definitely, working on the partnership between 988 and 911 is one thing that, that's a challenge, because they're different systems. 988 is largely run, except for in Lancaster County and Philadelphia, run by nonprofits. And obviously 911 is a governmental function, but 988 is the FCC designated emergency behavioral health line by the federal government. But we can talk more, Judy, about this, the deployment of mobile crisis, but it is. 988 call takers supposed to be licensed. So ideally, we will have folks who work at 988 call centers who have an LBSW, so that they could perform that function, so that they could say, "This is, yes, I'm talking to this person. It meets the standard of that's appropriate to deploy a mobile team." So I can, so I'm going to sign off on it and deploy a mobile team. The technology around how they deploy a mobile team is definitely an area that we need to unpack. As I said earlier, Virginia has this amazing software package that they use statewide. So we'll have to figure out collectively, 988 call centers, counties, mobile teams together, how we're going to do this, because it's a big lift as a county administered So Tracy, there is no option to license other bachelor degrees. There is no other license that is federally recognized, that is nationally recognized. Only the Council on Social Work Education has ever done the work to have a bachelor's level license, and it has a bachelor's level exam, and it is recognized and in place in many other states already. And if you know, I think the BSW is very strict, and there's not much flexibility in terms of courses, and there's required placement. My undergraduate degree is definitely not in anything that was licensable, because it's very much of a liberal arts degree. And so social work, though, there's very little freedom for BSW students, and they are required to do a 450-hour placement, which is something I want to point out, is that they can now be paid in their senior year when they're doing their 450 hours. And the vast majority of BSW students who don't go on for an MSW stay at their place of employment. So there just is no other equivalent for any degree except the social work degree. Should an existing MCI, should they become part? No, I mean, if that's to work on mobile crisis, folks we have not changed the other standards. So the standards to work on mobile crisis, that are in the state plan, which we can, the state plan language for crisis is very accessible. If you go to our website, DHS's website, and type in the Pennsylvania Medical Assistance State Plan, and then use a little search function and type in crisis, you can find the state plan. And the state plan is what we submit to CMS, Center for Medicaid and Medicare Services, to be able to bill MA. And so we have not changed the current requirements that are there within the state plan. So as long as someone meets them, and those will be outlined in the regulations, that draft regulations, when they come out for public comment, so folks can comment on those. But they're not different. So all crisis workers do not need to become CPSs, because they can, like I said, it's still a master's degree and a certain amount of experience, a bachelor's degree and a certain amount of experience. All of those make you qualified to work in crisis. Just we've added any certified peer professional. And I will just say that it is a very, very big push, as Steve mentioned earlier, the national level, that, and if you all think back, to the beginnings of the domestic violence or the rape crisis movement, who responds to a DV victim or a rape victim right after it happens has always been a person with lived experience, right? So it's that moment of responding to a person with lived experience and being able to connect with them and help them believe they'll be okay, and that you'll help them figure out a pathway to be okay. That's why there's such a big focus nationally on peers, that someone doesn't need to become a peer just to meet our crisis qualifications, because the master's degree and experience, the bachelor's degree and experience that are outlined in the state plan and in our previous, standards will stay there. We're not everyone doesn't need to be a peer. We're just adding that as an opportunity. And I use this as an example sometimes. If you think about, say, a veteran who, comes back with PTSD, has, never had any contact with the mental health system, and all of a sudden they go through that experience and they really are transformed by it, and they want to help other people, but they don't have a college degree. Or if they do, they have a degree in, something completely not related to our field, which obviously our regulations require a related degree. They would then be eligible to be a peer. They've had a PTSD diagnosis. So it just opens up that lived experience perspective and who could join that. Just like if and when we're able to create family peer, that would be the family member of someone with a diagnosis. And all of this is also, I just want to stress, we're now talking about the basic regulations, and we're talking about training that we're working to provide. But, there will be more conversations to come about things like kids crisis, responding to children in crisis, and working with families, because like Ohio has an amazing model for that. And so there's, and I realize in the real rural parts of the state, you're thinking, how are we going to even get two people 24/7? And in other parts of the state where you might have more resources or more people, therefore, the ability to have specialized teams, things like the children's crisis is definitely something that our Children's Bureau is doing a ton of work, really learning and figuring out sort of some best practices that they want to share. So I just want to make sure that I stress that as well. And our training that we've worked on for the crisis intervention training does also look at different population needs, like, you know, responding to older Pennsylvanians, responding to folks, LGBTQ individuals, responding to people of color, like responding to, I call them new Pennsylvanians, other folks refer to them as immigrants or refugees, but like, how do we think about crisis and being able to be impactful regardless, you know, with lots of different audiences. Oh, this is a fancy question. Any plans for state to start a statewide mobile dispatch approver center so that licensed clinicians can be centralized to approve call center dispatches, alleviating the need for individual call centers to find and hire and recruit those licensed individuals? Well, I think that the concept, we're open to all concepts. I mean, right now, the thought was if we could get LDSWs, since they're bachelor level individuals, to work as 988 crisis call center folks or as mobile crisis, it would allow that to be a local and instant thing. We have not had a conversation about a statewide mobile dispatch approval center. Not saying we won't have a conversation, but it doesn't, once again, you're talking about clinicians, and these folks, they don't have to be a clinician to recommend mobile crisis. They do for, you know, obviously the intent for like other services is such, but when we're talking about crisis, it's really more about that immediate response. So we're definitely open to figuring out how we are as helpful as possible. But like today, this afternoon, I'm meeting with the BSW program directors from across the Commonwealth to work on a strategy to help them know they have all these students who need field placements their senior year, and crisis and actually community mental health services is never discussed. You know, school social work, hospice, hospitals, private practice, child welfare because of CWEL and CWEB, but working in crisis services is not something that students are given any information about. So we're working on how do we do a campaign to recruit, because there are schools of social work in every nook and cranny of the Commonwealth. The PowerPoint will be shared. This has been recorded, and I think you'll get an email about that from this system. So are there any other questions, or is there anything you're sitting with that you think you heard but you just want to clarify? Because as I said, our goal here today is to help you mobile crisis providers understand what's coming and be able to ask questions, and also, you know, to feel somewhat prepared and not have any, oh my goodness, you know, anxiety about what might be in the crisis regs, because I hear that from folks, and that's not our intent. While we are working through some aspects related to the emergency behavioral health crisis walk-in center, because obviously that's very different than what a walk-in center is now, because it's staffed with medical professionals. Other than that, the regulations are ready to go up, you know, through the process and out the door, but we are just working on a few little issues related to that, because it is such a different model than what a walk-in center currently is. Access to the virtual trainings that were mentioned. We are loading them up now. If you go to my SAMHSA, if you Google my SAMHSA, just like it sounds, you should be able to find that, and you should be able to find the landing platform, and as we load things up there, you will be able to access them. You have to make a registration, costs nothing, and you will be able to see the trainings. We have several of them done. So what happens is the content person has to create them, and we've gotten experts in the field to do that. And then there's this whole process I don't really understand, where they turn it, you know, some of them are recorded actual people talking, some of them are digital, you know, they're online learning. They're not just like me talking to the screen right now. And so then they get loaded up. what is the expected time frame now for implementation? I assume we mean of the crisis regulations. Well, once they go out, you know, for public comment, then we have 30 days out for public comment, then they come back and we need to revise them. It is my intent to revise them as quick as possible so that we can get them back out. But then there's still a year after that before providers are held to them, as you all know. So once they go out for public comment, because there are factors beyond the control of DHS that determine when they're released to the public, then I would feel comfortable giving a time frame. There are many factors beyond our control until that point. Does anybody else have any other questions or comments? Well, I'm not seeing any additional questions or comments. So once again, thank you for joining us. I know this is a significant change. We want to do this change together. And, you know, like, just want to point out, I know the Crisis Intervention Association's conference this year is going to have several workshops related to the transformation of the crisis system. If you haven't heard Dr. Margie Belford speak, she is one of the architects of kind of SAMHSA's vision. She runs an emergency behavioral health walk-in center in Tucson, Arizona. She's going to present at NAMI Keystone's annual conference in Harrisburg in May, and she is very articulate about the whole continuum, because Arizona has the whole continuum, kind of how we've ideally described it, because they started this work in the 80s. So there are opportunities to hear from folks who are doing this in other states, them coming to Pennsylvania. And so we would hope that you would think about attending those. Or if you would like us to help you connect with somebody in another state, we are always happy to do that as well. So thank you for your time and your attention and all of the amazing work you do across the Commonwealth of Pennsylvania. We're very appreciative of what you guys do every single day. So once again, we look forward to talking to you in the future or seeing you out in your community. Thank you all very much for your time.